I'd like to welcome Deepak Ravindran. Yes. He's a consultant in pain medicine at Royal Berkshire Hospital in Reading, with over 20 years of clinical practice in pain management. So we look forward to what you have to say.
Thank you so much. Thank you to the British Porphyria Association and Sue for inviting me the second time around. How many of you were in Reading last year? You got a few, excellent. So some of this will be hopefully a helpful revision, but for a few I've got a lot of new material, and more importantly what I hope to get across to you in the next probably 45 minutes is to actually give you a whole set of tools to explore and look at in terms of pain management, rather than restricting yourself to what you think right now you've been doing. I said that, and I'm sorry if I made that assumption, because a lot of my patients, when they come to see me in my pain clinic, often stay within a couple of narrow treatment options without realizing that there's so much more to be done. And hopefully the next 45 minutes I'll help you to realize that you can explore a lot more that is within your reach. So to me, porphyria is a condition that, as an anesthetist, I used to see a few acute intermittent porphyrias, but in the context of them coming for surgery, where it would be an unexplained abdominal pain, severe pain that comes through, and I had to take a patient to theater. We would think it was an appendix or some kind of a burst tummy there, and then when we'd open and have a look, nothing. And the surgeon was inside. He'd say, you know what, I'm here, might as well take an appendix out and come out. You laugh, but actually, when you've gone in to do a negative, what we call a laparotomy, you open the tummy, but you can't find out, everything looks normal, you at least say, well, the appendix could become a problem there. It was something that we used to do up to 10 years ago. At least take the appendix out so that in the future it doesn't become a problem. And I had a few patients that way, and that was what my focus was. But in the last 10, 15 years of doing chronic pain management, seeing the occasional patient with porphyria, but more importantly, managing patients in the community, straight from a GP, sometimes in an intermediate setup, then when they come from surgery to the hospital, then after surgery, when they're recovering in hospital, I get a breadth of seeing how they struggle to manage with their pain, how they cope with their pain, and actually realizing that sometimes in hospital, we ourselves are confining our patients to only a narrow stream of choices when there are other things to do. So today I'm going to talk to you about specifically porphyria pain. In other sessions, I know that some of you have attended the other sessions in the morning that has been covered in bits and pieces, but I'll cover a bigger picture and put it in the context of actually the epidemic of chronic pain in general, not just from porphyria alone, but from other conditions as well. And lastly, this should hopefully give you an opportunity to understand how to manage pain, and I'll give you a mindset approach of what are the various therapies you can use for pain. I actually looked at, well, when you say acute intermittent porphyria, are patients with AIP, because that is the most common painful presentation of porphyria that I see in practice there. And I wondered actually, what is the evidence and literature out to say, are they pain-free between flares? And this study came out at the end of 2018, which it was a small number of studies, just 19 patients. But actually in that study there, they found that 18 out of the 19 patients, the pain was just chronic. It was present in between the flare-ups that they had as well. The descriptions you can notice here, some days I hurt so bad. So even when these patients didn't have a flare, they had significant pain between the flares. So intermittent porphyria doesn't behave like intermittent porphyria. Is that your experience as well? Yeah? So there is that level of chronicity. Show of hands, how many of you have porphyria but do have other chronic pain conditions as well? Okay, quite a decent number there. And it is something that we realize that there's always an overlap, because that overlap is important. And if you look at the amount of that overlap, chronic pain in general, you are looking at roughly 28 million. The data actually says that 28 million of the UK population, that's almost 40% of the UK population as per the last census, has chronic pain, meaning pain that has lasted for 3 months or more. And that's the kind of numbers you're having. 4 out of the top 10 disabilities that occur in the whole world are essentially pain conditions: back pain, neck pain, migraine, and abdominal pain. And essentially, we still are struggling because there are not that many pain clinics across the UK. So for the amount of problem that pain causes, the number of services that are fully equipped to deal with it are still completely very low and very poor. What does that mean? Scroll works, but not that one, no? Chronic pain is now being defined as a long-term condition. 400 million pounds are being lost in disability due to chronic pain annually in the UK alone. And pain patients for porphyria as well, they attend GP's visits much more frequently. And realistically, porphyria is present in 10 per a million of the UK population, where you've got 40% of the population struggling with pain of various kinds. In fact, there's more people with chronic pain than all of the diabetics and all of heart disease put together. And that's not a statistic that's very well appreciated. We pay more attention to managing and curing heart disease, but you realize that actually the biggest cause of economic productivity loss in the UK is back pain and chronic pain. And that does bring the question to me when I was preparing for this talk as well. I want to actually ask, well, what is different in porphyria? What is the reason for pain in porphyria? Because my interest is, when I treat patients, I like to look at the root cause, go upstream to actually find out what is it that causes the pain in porphyria, what kind of porphyrias are prone to having pain, and I think you all will know that a lot more there. And realistically, once I understand what are the root causes, then that gives me opportunities to see how to change it. Because these are the conditions of porphyria that I'm aware of, and as far as I know, it is this group there, which is the acute porphyrias, that are most commonly associated with pain as far as my pain services are concerned. I know that EPPs and CEP is quite rare, but I have a fair few EPPs that do come with pain as well. PCTs, I've not had any opportunity to hear, and from a few patients I've spoken to this morning, I don't think they have pain due to the porphyria itself. Is that your appreciation? Any PCT patients in the audience today? No? So I'll take that as a proof that pain is not a primary problem in them, but most of the acute ones, they have pain. And the difficulty is that with porphyria, the research even now is not fully clear. So one of the reasons is that most likely that the product of the intermediate synthesis, the byproduct that builds up, is actually affecting the nervous system and the immune system in the gut. When it is produced by the liver, it affects the nervous system in the gut and causes damage at that level there. The other thought process is whether the blood flow to the intestine is reduced at that point of time, and is that then causing the abdominal pain because not enough blood flow is occurring, not enough oxygen is going to the intestine and to the nerves, and is that causing pain? The third is, we do know with EPP and cutaneous porphyrias, the exposure to sunlight makes it phototoxic, brings about new chemicals that then again irritate the nerves that are just under the skin, causing the symptoms there. We know that when people have had this, and I'm going to go through that in the recent slides, is when you've had a couple of times that the nerves in the periphery under the skin or in the intestine or in the area in the liver side get repeatedly stimulated. It's almost like one of the patients in the previous talk was saying, there's that muscle memory. The brain and the body starts to remember that this is where it comes from, this is what I need to be ready to protect, and it goes into the tightness. So the recurrent attacks bring on a chronic pain of their own. So even though you may not have an actual product of ALA being deposited or your synthesis causing products to come along, your chronic pain will still persist because the system has got sensitive. It's almost as if your pain threshold has been lowered in that area, that you don't need ALA to be produced new, but the symptoms will persist there. And you know that for these therapies, we've got hemarginate, we've got GnRH analogs that have come through. I know somebody who's now, Liz told me that she's been on the givosiran for the last 2-3 years, so there is trials going on of this. So there are new drugs coming up and new treatments coming up which can reduce the option of the acute flares or the reduction in the amount of ALA produced. But what it does not sometimes change is actually the possibility of the chronic pain, the sensitization. And the reason that happens is something that we have to understand, because once you know what that is, then it opens up the opportunities. And to make it simple, I teach all my patients the concept of this pain-free mindset. And the mindset is an acronym that I use. For some reason that hasn't come through, but actually, wonder what has happened out there. So in that area there, that box there is medications. I think the font has changed out there. So that you see is medications there. And then we have interventions. We often get stuck in hospital medicine, and all of us stay within the medications and the interventions. But the evidence right now, scientific evidence and the evidence that you've heard from so many other lectures, I just walked into the previous one with Porphyria on, and you talked about lifestyle. There is a huge number of studies that talk about diet, about the importance of sleep as far as pain is concerned, the importance of exercise and chronic pain, and finally therapies, when I mean mind-body therapies such as yoga, mindfulness. You've got a taster session out there. All of that have a big role to play in how chronic pain can be managed or minimized or sometimes completely overcome when you can put all these therapies in place. So I had that, so the M and the I, and then the N here stood for the neuroscience. How you understand the science of the nervous system and why that is so important in managing your pain. Because that has opened up completely new ways of understanding why is it that people who have mental health issues experience more pain, why people who have other chronic pain conditions and autoimmune conditions experience pain, why sometimes pain is so individual to everyone, why sometimes people can describe pain in colors while others can talk about it in pictures, others can describe it in words, and others will be able to write it out or just shout it out. All of this has a reason because we now understand with the help of technology and science how the nervous system changes. And that gives me the option to actually say that if you are able to expand your thinking to change from just the medications and interventions alone to include the entire mindset, you offer yourself many other strategies that should give you hope that I have patients with who have overcome the pain and who have made a remarkable improvement. And that does not apply just to porphyria, it applies to chronic pain in itself. With that thought in mind there, we come to medications. Now, how many of you know any painkillers? Give me some names of pain medications you've heard of. Shout it out. Tramadol, morphine, paracetamol, codeine, diclofenac, yes. Gabapentin, pregabalin. Any other names? No? So, with very temperamental flicker. When we focus on the acute attacks for pain itself, I've stuck again. I want to look at porphyria first of all because that's important to all of you. We've got the various treatments that you know for managing acute attacks of porphyria. Opioids are used when you're admitted in hospital. We can give them as oral opioids. We can give them as injectable opioids. We can actually give them as IV infusions where we hook you up onto a monitor and then you give you a machine and a pump and you press the button, a patient-controlled way of giving yourself more morphine or oxycodone to get that pain freedom there. It's useful for acute attacks, brilliant. Opioids, whatever you may read in the paper about causing problems and addiction, all the stuff, in the acute setting, when you're in hospital there, they are very, very good in doing the job that they're meant to do. Other reasons for managing acute flare-ups, you've got carbohydrate loading, you've got arginate, and then you've got liver transplant, givosiran, all of that's come. All the pain medications that are available in the market are safe for porphyria. There's nothing here in this list that is unsafe, so you don't have to worry. Most of the medications are completely safe, including cannabis, for those of your interest. And all these medications that you listed above there are broadly divided. You've got the simple drugs that all of you have told me, paracetamols. You've got the mild opioids like codeine. You've got the stronger ones, that fentanyl and oxycodone and morphine. You've got antidepressants and nerve pain tablets like gabapentin, pregabalin, amitriptyline. All of these are there. They're all excellent drugs. And when you look at it, there's about 30 drugs out there. And you might be wondering, well, what's the right one for me? And the research has actually shown that when you're looking for the right one, it is very difficult. Because the reality with all the research that's come through is only 30% of the pain relief tablets work in 30% of the patients, only 30% of the time. That's about it. So if you're wondering why your pain medications haven't worked for long or stopped working or aren't there, this is really the research reason. And why, therefore, you do need to be open to trialing. If you're going to look at, I want a tablet from your GP, then you need to be saying, well, you know what, okay, I've tried this hasn't worked, can I try another one? And you're going to come across sometimes GPs who say, well, no, if this one hasn't worked, then you're not going to respond to any of the others. That's what we're trying to educate GPs as well, that that's not necessarily true. People have to be trial and error, and you've got to find the right drug. You might very well be that 70% that doesn't respond to most painkillers or gets side effects that make it unsuitable. But that's important. We need to go through the process because medications like these are not the answer by themselves. And you might be wondering, well, you know, how do these medications act? You know, why do they work and how do they fit in? And if I have to show what they do, let me use this. So if you have this, for example, let's say if you're an EPP patient or if you're an AIP patient and you get your flare-up and it's in your tummy, pretend that that part there is the point where the ALA is being generated, those products are come along and that has irritated the nerve at that level. The signal travels along there to the nerve and arrives there in the spinal cord in the back over there. That's the spinal neuron, and that's where the signals are coming through. Observe, I'm still talking about the signal. It's not the pain. It's the signal, chemical signals that are coming up to here. This spinal neuron, which is located in your spinal cord, then sends it onwards to your brain. Your brain then says, well, you know what? Where have I had this before? When did I last have this? What did I do the last time? Because I need to know if I can do the same thing again, because that's how I'm going to protect now. And that's the process it goes through, the predictive process of where has this pain come from, which area is it coming from, is it something that I know or not? So if it comes from your tummy and you're an AIP patient having a second flare-up, you'd say, yeah, this is another flare-up. If it comes from the back, you're going to say, well, you know what? What did I read about the back? Oh my God, is it the disc? You don't know whether it's a disc or not, but then your brain has decided, well, from reading newspapers or from your family or from your father or your mother, that's what they said it is. Well, that's what it's likely to be, so it's probably that. So it's that prediction. Could it be wrong? Probably. Could it be right? It could be. But then you've got to remember that this is the brain making the prediction to decide what's the signal mean. And then it decides, well, can I respond to it right now? If I'm if I feel or step on a hard stone and I'm just crossing the road, then I could respond in pain. But if I step on the same stone and I'm on a rail track and I see the train coming, then that's really not my necessity right now. The first is to get out of harm's way. Yeah? So the brain will decide, well, do I need to block that signal out for a little longer to get me to safety, or do I need to respond to it? And the brain is able to do that by saying it has got descending inhibitory. It can block out the signal from coming up too high, or it can actually amplify the signal by a different mechanism. And the brains can do that. And that makes an understanding, because if you look at how these signals are coming through, it's that balance between the descending blocking of the signal and amplifying the signal that decides often whether it's porphyria or chronic pain, why your pain stays persistent. That balance is changeable and is reversible. But that balance, when it goes wrong, is when patients start to get a chronic pain and your porphyria or your AIP or your back pain or your neck pain starts to become more chronic and persistent when the balance is wrong. And therefore, it means that when you then look at, well, where do the drugs act? If you think you want to block the signal from coming up, that's when we give drugs like amitriptyline or duloxetine. If you want to block the ALA, that signal that irritates the nerve from actually coming up, more signals from coming up to the system itself, that's when you think about lidocaine patches, local anesthetic, drugs like epileptic drugs, that's how they act. If you want to prevent the signal from jumping into the spinal cord, that's where you want to use gabapentin or pregabalin. I show this slide to say that when people say, oh no, if you're on one painkiller, you can't have another one. But actually what we tell GPs is that because these are tablets acting on different parts of the system, it's useful to actually have small doses of 1 or 2 painkillers at the same time. So you can take a paracetamol plus a non-steroidal. You could combine a codeine along with paracetamol and possibly a gabapentin because they all act on 3 separate different pathways to give you an overall better quality of pain relief than just taking 8 or 10 tablets of paracetamol and getting worked up as to why it's not making a difference. Because the system changes. And that's useful to know there because you could have other ones. You could have actually so many different kinds of morphine because they act on different parts of the receptor. You can have patches, chili patches, which can help if your pain is very localized. That may be a reason if your skin's not broken in EPP and your area is very localized, then you can look at patches like this, local anesthetic and capsaicin patches. That's something to think about. Next strategy is interventions. Now with porphyria, there are some interventions. You have got the arginate-like, you've got liver transplant, you've got afamelanotide for EPP that's been approved. But what about other interventions for pain? All of us have back pain, neck pain, and we sort of think, oh my God, it's probably the disc. Oh my God, it's probably the joint. Or you get a pelvic pain and you think, oh my God, it's probably the ovary or something in there that needs to be looked at. Or you need something to look into the bladder. And what they have done is, again, with the same principle that are used for medicines, when you look at it, musculoskeletal, back pain and neck pain are the most common pain problems that most people have as we grow older. Now, these are various studies that have been done. Can you believe that these were studies that have been done on people who have no pain? So they took patients, 3,000 patients who have had no pain in their knee, and they did an X-ray and an MRI scan of their knee. And what do they have? They had 43% had changes of arthritis. They didn't have any pain. But 50% of the X-rays had arthritis changes. They had cartilage tears and meniscal tears in 30% of the patients. They had no pain. They've done studies on the shoulder, 2,000 patients who have no shoulder pain, but they have rotator cuff tears, they have signs of bursitis, and they have changes in the joint of arthritis. Up to 60%. They don't have any pain. So actually the picture, even though you want to say it shows 1,000 words, it does not talk about pain at all. That's one big thing we've realized now, that in the 80s and 90s, even when I was doing medical school, we were told, you have pain, get an X-ray done, and your X-ray will tell you where the pain is. The sad, sad reality is that the X-rays or MRI scans are just a snapshot of that person at that time. They have absolutely no relevance to the intensity of pain that you are experiencing or undergoing. You might say, no, that's not the case. My surgeon told me my back is the problem. My disc bulge is the reason for pain. But actually, look at this. An MRI scan shows of 50-year-olds, 80% of 50-year-olds have disc degeneration that is completely asymptomatic and they're not in any pain. 60% of 50-year-olds have disc bulges, no pain. So the reality is that we can't be sure that the scans do tell the picture. We have got the story last year. You saw this. I don't know how many of you saw this on Horizon BBC program about a group of people in Blackpool. Mike Mosley conducted this experiment. He said, we've got this obvious, fantastic new pill. It's a blue-colored pill. It's a new pain relief pill. We want 100 people to participate in this. 50 of you will be the control group who will get possibly a placebo or sugar pill. 50 of you will get this awesome blue pill that we are trialing for pain. And so they signed up, 100 people signed up for it, and they went through the experiment for 3 months. 3 months, they got the standard. They didn't know what they were getting. We just knew 50 people probably got the control one, 50 people got the blue color pill. Because it was blue in color, the people who got the blue pill thought they were getting their drug there. So that's how the study was done. 3 months later, they were all called there. And this TV episode is fantastic. You must watch that. They had people who were taking the blue pill, who were wheelchair bound with back pain, were able to get up, start walking again, get that good pain relief, and start to go on their first barge trip down the, I think, near Manchester side. They were able to go attend the Blackpool trip. And they had this really good story there about patients getting such good benefit from there. But 40% of the people who were supposedly taking the control pill also improved. They also improved, had good pain relief. They didn't know they were taking the control pill. They were just taking it. Then when Mike Mosley called all the 100 people and told them, okay, thank you so much. Those people who've got the blue color pill, the new drug pill, 55% of you have really improved. Those of you who did the control pill, you guys had the control pill, 40 of you improved. And then he gave the shocker. The 55 people who had improved had also received sugar pills. It was just the blue color pill that seemed to make a difference. So there was something in the placebo effect that seemed to make a difference there in making people come from pain. So these are things that we're realizing that it's not really cut and dried to say the structure is the reason every time for the pain. And that changes because we now got the proof and studies have been actually done that when they've gone in and done surgery, so 2 studies were done on shoulder keyhole surgery. One of them, this was for the back one, but a recent one was done for shoulder surgery. They did a keyhole surgery and they put patients, they took them through to the surgery, they anesthetized them, they put them on the table, and then they were in the trial, they opened the leaflet, and if the leaflet was shown to the person who was investigating that the person should not have surgery, then all they did was put 2 holes in there, and didn't do any of the cutting. Keyhole in the shoulder came out. The other group of people had the full keyhole, shaving of everything on the shoulder. They all had physiotherapy afterwards for 6 months. And then when they were examined after 6 months, the group which had no surgery and the group which had the full keyhole surgery recovered to the same extent. No difference. And the same with back. And that's why some of you may be in a situation where you've noticed that in many parts of the UK now, keyhole surgeries for the knee, for the shoulder, have all been stopped being funded by the NHS. Because there is no evidence that actually just doing cleaning up of the knee or the shoulder necessarily changes the outcome, because if people can do good physio and do other weight loss regimes, the outcomes are the same. So that's why some of you may be at the receiving end of this, but that's the reason they've made the change. Because that's important to know. And we teach our GPs and our surgeons and all the chiropractors and osteopaths, please don't use language like this, because this language is unhelpful for patients, because that really doesn't happen. Your spine doesn't crumble. The reason is that when I say something is crumbling, you're going to think of the Twin Towers, because that's how your brain processes. Your brain processes in terms of stories and pictures. You will think of something that crumbles. But actually, in reality, the spine never crumbles. The discs don't pop out or pop back in. It's nice, it's simple to explain it, and it's understandable. But in reality, that doesn't happen. There is a bulge, but as I've told you, the bulge need not be the cause of pain in everyone. And that's important because we now understand so much about pain. We now realize that it's not in the head. Pain actually is very, very real. The signal that makes it changes. I'll tell you the story there. It came out in 1995, but this was a story of a builder who jumped from probably a height of 10 or 15 meters, and unfortunately had this go through his foot. He was in agony. You can just imagine. The story talks about how he was writhing in agony at the building site. Nothing could be done. Nobody could touch him. He refused to have anyone do him there. Ambulance was called. The ambulance took him directly to A&E. A&E couldn't do anything. They tried to give him some gas and air. He just completely refused. Threw completely all his toys out of the pram. The beeping noises and E&D, nothing could do. So they had to take him to theater. The anesthetist then takes him and says, okay, we have to give him a full general anesthetic. Knocks him out completely, tube in the throat, fully anesthetized. And then after that, the surgeon comes along triumphantly, pulls out the nail, takes out the boot and then wants to clean it up. And what does he find? The nail has gone between his first and second toes. It hasn't scraped and touched his foot at all. But you can't deny he wasn't in pain. Nobody could deny with that kind of picture he wasn't in pain. So we know that pain is very much something that we've realized. And the definition of pain itself is there. Look at that. Pain is a somatic experience, a description of how you feel, but it would reflect a person's apprehension of threat. So if there is a threat to your integrity, to your bodily integrity or existential. So if you got people who have heartbreak and you got emotional pain, you've got that also accounts. The same areas of the brain light up because it's still a threat as far as your brain is concerned to you. That's why even in acute porphyria, when you've got chronic pain, your acute episode could be because of the ALA. But the chronic one, when it stays on, when your EPP stays more constant on, it's going to be possibly because your brain and your nervous system has recognized that it's something that it is a threat and that it needs to protect against. And it would do what it needs to protect because that's what it's for. And in there we realized actually that there's a difference. Can you say the word with me? Nociception. And nociception and pain are different. You remember I told you chemicals are brought forward from the nerve. Those chemicals are actually nociceptive signals. So when I measured this there, what happens there when your ALA gets registered and the chemicals come along your nerves, those are nociceptive signals. Nociception occurs in all of us all the time. Right now, if you stub your toe there as you're running out after when a fire is there in the room, your nociceptive signals are the same as if you stubbed your toe and you're completely fine and you yowl out because you stubbed your toe. But if there was another danger there, your brain will decide that's not the pain to be worried about. First, getting you to safety is important. So nociception is the signal that always occurs, but pain is what your brain decides depending on the context and depending on how important it is to protect you. And that's important, and it achieves that, as I told you, by these signals that come on either side. What's more important is actually this part here, that where the brain changes because of this imbalance there, there's another pathway here that starts from the spinal cord. Those are separate signals that come to your emotional centers. If you've thought about why pain spoils your mood, why it affects your depression, why it makes you cry, why it makes you angry, sad, or upset, is because that same spinal cord neuron that gets wound up sends chemicals through a different way to what's called the limbic system. This is the part of your brain that's responsible for emotion, for mood, for anger, for fear. And so that is a direct shortcut that's produced over there, which is why your pain affects your mood and vice versa, why your mood affects your pain. Because they're related to each other, because they in turn wind up the whole thing. Go on.
You get the receptor to say that you're in pain, to tell your body you're in pain to move away from the object or whatever. But why does it tell your body to be sad or angry, or why does it do that?
These are primitive protective pathways that have been there that are actually baked into our system, because having that low mood is sometimes, in the olden times, was protective. Because if you stayed in a cave, then at least you didn't get eaten up by the savannah tiger outside. It's not relevant in today's world, but actually if you were low in mood and you stayed away and you hid within yourself and you hid yourself from the outside stress, then that at least protected you and made you survive just that 2 days longer. And that was what allowed for that to happen. It doesn't work in the long term. It's not useful as a protective strategy in the longer term, but it's a strategy that gets poorly adapted as pain gets progressive. And what we've realized is that there are changes that happen in the brain, there are changes that happen in the spinal cord, and you realize that when I'm saying all of this, nothing has changed in your ALA new chemicals coming up. This is all changed between the brain and the spinal cord. This is completely independent of what happens in your EPP, in your AIP, in your back pain, in your disc, in your irritable bowel, in your pelvic pain, in your migraine. This is all somewhere far, far away. All of this has happened in the spinal cord and the brain. And in chronic pain, this phenomenon of central sensitization is what we need to overcome if you're going to get completely good results with your chronic pain. It's not so much the hemarginate, all of those will work if there's a peripheral problem. But when you realize that why sometimes your arginate doesn't work that well, or why it's not that effective, or why various treatments for porphyria don't work that effectively, you've got to think of this as a possibility and also go after this. Because with porphyria pain, really, you may not have necessarily a nerve damage every time. You may have a low blood flow, like I told you, to the intestine that sets off a flare. You may have some other metabolic problem where something else is released. You may have a toxic release of some of the products of phototoxic. So your nerve may not get actually damaged, but just gets oversensitized. As somebody said, just get shot. Your nerves get shot. And in those kind of situations, the nerves themselves start to generate signals. And those signals get really complicated. That kind of neuropathic pain is something that we are still researching to get newer drugs and molecules. And we are still about 10, 15 years away from getting targets when the nerves have been damaged. Sometimes that happens in porphyria patients. And that kind of sensitivity is called peripheral. But I've already told you about the central sensitivity, and I've told you about how the brain itself changes. And it's important that you have that in mind, because once you realize that difference, it gives you the options that, okay, I've managed the peripheral part with the help of arginate, but can I do, what else can I do for the central parts? Because what you've got to realize that the body uses pain as an alarm system. Pain is not going to tell you when everything is wrong. Pain only tells you what is an alarm. And the alarm should be set normally to recognize when an intruder enters your house. But unfortunately, the alarm can sometimes be set that it will start going off when a leaf falls or a cat goes past your house. And that alarm system can become maladaptive, can be oversensitized. And that's what causes chronic pain in a lot of places. What we've now realized is that the alarm system can be flexibly, can be plastically upregulated, but it can also be downregulated because you can change it. You can change it using various techniques, not just drugs, but you can use electricity, or you can use so many other therapies to try changing it. That plasticity is what's very, very useful, and it's being used both in mental health and in physical health conditions. Because what we've realized is that nerves that fire together, wire together. Imagine when you're learning driving for the first time, you had to focus on 8 or 9 different things: mirror, signal, maneuver, watch, turn left, look right, look left. Take all those 20 different complicated steps of what your left hand has to do with the clutch and your right hand has to do with the accelerator, putting the indicators on, your left leg, your right leg. Now, many of you may just have driven up here in half an hour, not really realizing what's happening. You might have been changing the tuning signals on your radio station rather than thinking of the 20 complicated steps. That's because by practicing and learning driving as you're doing it, your brain has taken those 20 difficult steps and has condensed it into one good, quick network step that fire together quickly and make it easy for you. It's a good shortcut that's useful when you're doing driving, but it's not a great shortcut when you're having pain, because it's the same kind of shortcuts that come along when you're having anxiety, when you're having depression, when you're having panic attacks, when you're having mood disturbances, when you're having other forms of pain. It's those same networks that get set up. I tell patients sometimes, imagine that, like, for example, if you want to get to Waterloo. How many of you know London Waterloo? And you know Clapham Junction? Yeah? So Clapham Junction is a common junction that's there, from which trains can go either to the southwest, can you go to Reading, can go to Swindon, can go to Oxford and further up. But Clapham Junction forms a common node. Imagine that your anxiety network is like that. Clapham Junction forms part of your anxiety network if you're coming, let's say, from Reading all the way to Waterloo. But imagine if you're coming from Brighton and you're coming to Waterloo, and that's your pain network that comes along. Clapham Junction is a common junction there as well. So if you're having networks and nerves that are overlapping at Clapham Junction, and they are common for pain or anxiety or mood or porphyria or irritable bowel, then you can have one network that flares up, the other network will just automatically start off. And that's another reason why, when you ask me, why does mood and depression come there? This is the other reason, that nerves that are fired together nerves that wire together start to fire together. It also presents us the option that if you then start a new network that you can fire together repeatedly, you can make them wire together. And that's the principle when I spoke in the workshop about using techniques like yoga or Tai Chi or all of these. What we're trying to do is to teach a new set of nerves to fire together so that they can wire. And that's what we try to do. Neural networks are the way. If you think about your Alexa, your Siri, your Cortana, your technology interfaces, they're all been built on the understanding of our brain and how it functions in the last 10 years. That same technology is being used there as well. And that's important because we realize now that when I was in medical school, I was taught, well, your signals, pain signals come here. It then goes up to the brain, and there's a pain center in the brain. The pain center then will recognize what to do. What we've now realized actually is that pain is felt everywhere. The pain starts from all these are the 6 or 7 big structures. Probably next lecture, Prof. Jones will talk about it a little bit more in detail. But what we know is that when the signals actually arrive, multiple areas of the brain will be processing it. What does that mean? Why is that important? Because these multiple areas, for example, this area is responsible for your creativity, for your empathy, for intuition. This area in the back of your brain, the parietal lobe, is responsible for hearing, for vision, for seeing, but also for pain. These are called mirror neurons. Mirror neurons are the reason why you cry when you see a romantic movie or a tearjerker, the reason why you laugh when you see a humorous movie, the reasons you get frightened when you see a horror movie. Because your brain at that point activates the mirror neurons, so your brain recreates the same emotion that those filmmakers are trying to create, and that's why you do it. It's a presence of these. But then pain neurons are overlapping. The networks overlap in the same area. If people can see their pain or feel their pain or hear their pain, this is the reason, because of the overlap of the networks. The amygdala is your chimp brain, your reptilian brain, your monkey brain. Call it what you will, depending on which specialty you are. That's your fear center. That's your control center. That's your emotional center. That's your center that acts at a subconscious level. When somebody shouts at you, when somebody throws a stone at you, and you get instinctively angry before you can control it, it's your amygdala kicking into action. But pain resides at that place along with other fear and emotion. And all of these are acting with each other. Your hippocampus stores your memory. When you sleep, it's your hippocampus that archives the memory, looks at how you have gone through the day and archives the memories carefully and properly. When your sleep is disturbed, your pain cannot be archived properly, which is why your pain persists, because your brain just doesn't store and do a good job of the library in putting things in its right place and pockets it. That's important because in understanding how this pain is, if you look at a couple of these lectures, you get a chance on YouTube to look at this, why things hurt. It will make it much more clearer for you. And I would really urge, if you fancy this book, a little bit expensive, but it makes it really clear for you on the new understanding of pain in a very patient-friendly language, gives you so many other options to try. And the important thing to understand is these are not things to do when you're in a flare-up of pain. Just like you need to do when you're learning how to drive a car, I go back to the same analogy. You're taught how to do an emergency stop. You just aren't told, you know what, you can do the emergency stop when you actually are about to have an accident. You're taught as part of your testing thing how you put an emergency stop. What do? You look in the rearview mirror, then you see how safe you are, and you try to teach that. So you need to put some of these practices in place now when you're between flare-ups so that it comes to you instinctively when you're in a flare-up. It's important to think of that. So understanding this is important. Because what we've realized now, and you know, you might have heard about this in lifestyle and in other lectures in EPP about lifestyle. What I'm telling you is actually with pain itself. Do you know, how many of you have heard of the molecule dopamine? Yeah, what do you think that does? Happy molecule. What do you think serotonin is? That's also a happy molecule. Now, those are the mood chemicals. They are the ones that all your antidepressants are going after, yeah? So we think that you're going, if you're depressed and there, it's all going to be treated by taking some antidepressants. But did you know that almost all your serotonin and dopamine is produced in the intestine? 70% of your immune system, of your entire body, is in the intestine. 70% of your immune system of your entire body is in the intestine. 70% of your immune system of your entire body is in the intestine. 70% of your immune system of your entire body is in the intestine. 70% of your immune system of your entire body is in the intestine. 70% of your immune system of your entire body is in the intestine. 70% of your immune system of your entire body is in the intestine. 70% of your immune system of your entire body is in the intestine. 70% of your immune system of your entire body is in the intestine. 70% of your immune system of your entire body is in the intestine. 70% of your immune system of your entire body is in the intestine. 70% of your immune system of your entire body is in the intestine. 70% of your immune system of your entire body is in the intestine. 70% of your immune system of your entire body is in the intestine. 70% of your immune system of your entire body is in the intestine. 70% of your immune system of your entire body is in the intestine. 70% of your immune system of your entire body is in the Your intestine and the nervous system and the immune system in and around your intestine is the only part of your nervous system that is actually exposed to the outside world. Your brain just does not have any exposure. It sits in the skull. It uses the nerves that go to the eye to see and the ears to see, but everything else goes by understanding what's happening in the gut. And there are so many chemicals that are actually produced by the gut. Now, we talked about genes in the morning there. Do you know how many genes we have? You know, all the gene project that has been done to know how to sequence the genes. Do you know how many genes the humans have?
80,000?
We found out roughly between 24 to 25,000. Do you know how many genes the maize plant has? No. Around 32,000 genes. The rice plant has 40,000 genes. So plants have actually more genes than the humans. But how come we exist the way we are? That's because the microbiome. That's the entire ecosystem of bacteria and microorganisms that live in the intestine along with us, that have grown up along with us, that are responsible for modifying what we eat. It signals our immune system and our nervous system. It produces the dopamine and the serotonin, and it actually works with us to be who we are. So looking after your gut and your intestine and actually the role that plays in chronic pain is hugely important. The next 10, 15 years, you're going to see a lot more about understanding your lifestyle and your diet in looking at managing chronic pain. The reason I say that is you might have heard about vitamin D, magnesium, turmeric, prebiotics, all of this. They all are acting on trying to rebalance the microbiome, trying to get the balance between good bacteria and bad bacteria right, because the reality is that when you're eating the diet, the SAD diet, the standard American diet of today, or the MUD diet, the modern urban diet of today, which is full of processed foods and packaged foods, we are causing a problem. We are disturbing the ecosystem and causing an issue. With porphyria especially, this is what we recommend. Try to go off on processed foods, go for more healthy foods, go for more high antioxidant foods, go for more potassium-rich foods. These are all apparently recommended for porphyria patients. And you might have seen this BBC episode. It's not available anymore, went off BBC about last year there. But this was a very good coverage on understanding that if you're going to take processed foods, sugar-based cereals, deep-fried stuff, white rice, bread and red meat, they all can potentially worsen any pre-existing chronic pain by affecting how your hormones and your systems change in your intestine and affect your bacteria in your gut. So if you want to rebalance them, the way to look at it is looking at anti-inflammatory foods, looking at the balance between omega-3 and omega-6, considering a Mediterranean diet in its entirety, looking at a lot of antioxidant foods, whole grains, and considering vitamin D, magnesium, and all of that stuff. And so this is very important in terms of diet to look at. I come on to my next one is sleep. Hugely important. I told you that when sleep is fragmented or disturbed, or you take your blue light, we talked about blue light filters this morning in Dr. Batman's talk there, all of these have a significant impact on sleep. When you reduce less than 7 hours of sleep, the studies are coming out that it does cause predominant or early degeneration of the nerves, because it's during the 6 or 7 hours of sleep at night that the brain actually does its recycling job. That actually it starts to cut out all the waste products and take it out there. If you thought about why Margaret Thatcher and all these people who slept 5 hours and we thought, oh, they're awesome guys and they all get Alzheimer's, it's because Alzheimer's is not a fancy new disease. The realization is that in Alzheimer's or in dementia, often you've got deposits of plaques that happen at the nodes in the same networks. The reason is that when you sleep less than 6 or 7 hours a day, the chances are that the brain doesn't finish its recycling. Your recycling trucks that go through your brain in the night don't finish their job, so they dump half their waste in some places there, and then they carry on, taking as much as they can. That small dumps over time become a problem, and then they cause blockages, which then block traffic signals and intersections. So pay more attention to this. I know it's easily said than done. What you have to look at is something called sleep hygiene, which if you Google sleep hygiene, the American Sleep Foundation and the Sleep Foundation in UK gives some really good common sense advice. A lot of you may be already doing it, but consider implementing these in a slow process fashion. Again, important to do these in a gradual practice fashion now. Don't expect them to immediately give results. Give yourself 6 weeks. Add 2 things at a time each time, simple things to do. What I do completely advise, absolutely stop coffee after 3 o'clock in the afternoon. Stop 90 minutes before bedtime, stop your electronic devices. No kind of electronic devices in the bed. And try to make the bedroom something that you would do when you're teaching your 2 or 3-year-old to go to sleep is what you need to teach your brain back again. Train. Give it a new neural network to wire together, to fire together, and you'll notice the difference in 4 to 6 weeks' time. But that's what I would say as the top 3 takeaways there. Physical exercise, hugely important because we now realize exercise is not just about your heart, about weight loss, about conditioning. It actually builds new networks. It actually brings new networks that fire together and they will wire together. It's been proven that if you can get even 30 minutes a day, that is really useful. And for anyone in chronic pain, porphyria or otherwise, it's worth looking at that form of exercise there. And I realize that cat videos got quite popular. That's what we realize with exercise. And last, but definitely not the least, it fits my mindset part there, but I should actually be putting this first. But therapies of the mind and body are hugely important. We did just a workshop the last session, which we did exploring these newer things. Now, you all may be thinking, well, it's yoga or meditation. But the reality is meditation, mindfulness, journaling, expressive writing, different forms of yoga. Please explore these options because these all allow for a gentle, non-medical, non-injection-based way of rewiring the brain. Because as I told you, if you can take down central sensitization, you have your tools of arginate and all of that to manage the acute attacks. But you have to pay importance to the central sensitization part. Because what is most important to realize, I told you about nociception. Nociception can occur in all of us, every one of us. But the context and the affect, you can change. That's always in your control. That control is something that you will never lose. And harnessing that control is important. As long as you're in a medical system, waiting for the next drug, for the next injection, for the next appointment from a specialist to come 3 to 6 months, you're always not having control. This is always under your control. And if you can use various kinds of therapies, both online, offline, your practitioners locally, you can influence that because this is going to be a sum of that plus that. And this is always under your control, which is why all of these therapies have become more important now and the science backs them up. In essence, I would say that I generally like to look at myself as a more upstream Patch Adams-like guy, and I've had much more success in the last 5-6 years. I trained as an interventionalist, an injection and medication giver there, but in the last 5-6 years, adopting a much bigger mindset approach has at least been able to say that I have had many more victories than just saying the occasional, yes, pain-free. Okay? That about brings there. Any questions?
Testing.
Oh, yes.
We're on. The sleep thing. Getting over 7 hours a day, does that have to be in one stretch?
The ideal is, so there is a book called Why We Sleep. Came out last year by Matthew Walker. And what he talks about in there is that the night time is preferentially a time where you can train your body to achieve that sleep. So doing it in one bulk is most ideal. During the daytime, you tend to disrupt the rhythm, the circadian rhythm, where before all this artificial lighting came along, as hunter-gatherers or what we did till 1850s till light came along, our nervous system and our body has trained to realize that the darkness comes with it, that after 8 o'clock you decide. So that's where the block of one big bulk of 8 hours of sleep came along. Our introduction of all of this in the last 100 years has disrupted it, and we sort of think, okay, maybe we can snatch hours in the day. The research is not there to say that if in all you get 8 hours, it should be the same. I don't have the scientific research to back. Whatever Matthew Walker says in his book is that prefer to try to teach and train your brain to do it in one bulk at night time, starting anywhere between 9 or 10 o'clock and finishing by morning. Too muddy, crystal clear?
I think it's time now for the next lecture to
Absolutely.
start. So
Thank you so much.
Thank you very much. It's been very informative.
Thank you.